this was the sternal cyst.
Okay. I think we are live. Just like that. Man, the software I have, sometimes it gives me some questions to answer to prep for the live. And then sometimes it just throws me into the live, which it just did right now. Which is cool because I was ready to be thrown in. Let's see if we get some people to show up here. This should be fun. I know it's late on the West Coast, so hey, Laura's here. Hello from Chicago. Very cool. And Jen W, hello. And Jolene from Louisiana. Now people are showing up. Very cool. I'm going to give everybody a minute. I know it's on a Tuesday night. It's very strange. Louisiana, people staying up late on the East Coast over there. Ontario, Arkansas, Kathleen, Robin. Very cool. Everybody's showing up now. So, hello, Lorraine, Kathy from Sydney, Australia, all over. JTO from Sacktown. This will be cool. I put it on TikTok, so we might get some people from there. So hello from the people from there. Hello to the regular viewers. This was an interesting case, and she was excited to record it, and she even shared it with her family over the weekend after we did it. And she said everybody came in, was watching it, and they projected it up on the TV in front of the whole family. So that was kind of cool. And if she's watching, thanks for sharing so much. So this video actually got it's like 1.8 million, I think, views on TikTok. Just the intro video. No, it's at 2.3 million views just on the intro, which is crazy on TikTok. And I showed a little bit of the follow-up, which I'm going to show at the end of this, and so you can hear it with sound, because I showed a little bit of that on TikTok as well. But this was, an interesting presentation. It's one we've seen before, but just like everything, oh my goodness. Thank you. Nice way to end the day for sure. Laura, thank you for the super chat. Always appreciated. Very much so. Thank you. So whenever you see like this presentation, somebody comes in and they have a red nodule. A couple things you start thinking about, definitely in that area as well. In your differential diagnosis, you got hidradenitis suppurativa, you got bacterial abscess, an infection, and then you think of a ruptured cyst as well. And those are probably the three most common things you're going to see. Trauma, obviously, foreign body. These are all things that are going to be going through your mind as potentials. Then the history matters. So then you start, unpacking everything that's going on in front of you. So you're unpacking the suitcase. And what you do is, hey, a year ago, 2 years ago, did you remember feeling a little nodule or a ball there? If they say no, not at all, then you start thinking bacterial abscess, maybe an ingrown hair, a pimple she tried to pick, and possibly she brought MRSA or staph from her nails and she's squeezing into that area and got a secondary horrible infection. But if she's like, yeah, I did. I had a bump there for a couple years and it was getting bigger, which was her history. So that was interesting. And then you think, okay, most likely an inflamed cyst. And out of this, actually, I cultured it and no bacteria, which happens over around 50% of the time. There's no bacteria in these, even though they look like a horrible cellulitis or abscess. So it's important because a lot of people that comment, they say a lot of interesting things. And I can tell they're compartmentalizing. They're just seeing that in just what they've seen or their experience, which may be limited, or maybe they've seen a ton of videos, but they've just seen a ton of cyst videos. So they think, oh, he's just not getting it numb. He's not using enough. He's stingy because he's trying to save money. Or I hear all those things. So... And that's not the case at all. I actually put a lot of lidocaine in here. And what was interesting about this is if you look close on the initial presentation, there's a little line already in the middle of it. And I was like, that's interesting. I was like, did you get scratched here? Did you try to drain this? And she had gone just a couple days before, I think maybe 5 to 7 days before, to a provider that tried to drain this and couldn't. And I'm trying to remember. I'm pretty sure, sometimes that happens at urgent cares. They'll just try to get a little bit of fluid out, or ERs. But I think she said she went to a dermatology office. They numbed it up and they tried to cut it and drain it, and they didn't get anything out. And that was strange to me. And this is before I even started. She had told me that. And I'm like, that's odd, because normally, these things are ready to go. Now, was it possible? And I've had one like this that I've shown in a video. It wasn't ripe enough. It does take a little bit of time, and to get to the point where your body's having enough of an inflammatory response, there's enough fluid buildup that it's ready to go. And it directly correlates with the amount of pain, for sure. And that also directly correlates with if your lidocaine is going to work or not. Usually the more ripe it is, or the longer it's been there, the more pressure, the more of an inflammatory response. So, I'm not going to go too deep in it because I say it all the time, but the acid-base shift. And when I say that, if you look that up, there's a lot of acid-base shifts in the body. So when we're talking about metabolic alkalosis, metabolic acidosis, respiratory alkalosis, and respiratory acidosis, these are acid-base shifts that go each way. The kidney function is a lot of times playing a part, or what's going on in the lungs. And you're either going too alkaline or too acidic, which causes those, types of conditions. And there's so many precursors to that of why that can happen. That's not the acid-base shift I'm talking about. So what I'm talking about is we have a certain, acidity or alkalinity on the skin. And when we put in an acid for the lidocaine, it shifts, and that's what helps with numbing. So when there is a shift with that, and there is also when you have a huge inflammatory response, you are getting a shift from the more alkaline of the normal skin to a more acid presentation. So when that shift happens and it's more acidic, you're putting an acid on an acid, you do not get what you need to happen to cause it to be anesthetized. So that is the acid-base shift, and the acid on an acid, and why it doesn't take. And it's more so down in the pocket. And you can do tumescent, which Dr. Pimple Popper does, and a lot of plastic surgeons do, where you can infuse a saline bag infused with lidocaine and just flood the area. It takes a while when you're going back and forth. You can hit nerves. There's things that can happen when you're infusing that in. It's a little bit of a higher risk. It takes a lot longer, and it can really swell up the whole area. And it's already very tender. A lot of times, it can be pretty painful to get it there. So, and it doesn't always work. So, and I don't have tumescent numbing. We don't do that. It's a lot more involved. Plastic surgeons, Mohs surgeons, or people who are doing real large areas tend to have that. We're not doing super large areas like in an outpatient setting, so I don't have that. But that even being said, I can get the surface of the skin usually numb enough to be able to cut it, which I do. But directly under there, and what is happening is pressure sensors. We have nerves that are there and responding to pressure, and that's what's causing the pain. And the more pressure that builds up, it is pushing on the surrounding tissue, pushing down into really tender tissue with a lot of sensory nerves that are down there. And it gets to the point where they can't even take a deep breath. The lungs expanding into that area. And she was at that point. She was in a lot of pain. A lot of pain. And she actually hit it pretty well for the video, I think. But when I went in, and I just a touch to feel if it was warm, she drew back. It was that tender. So they don't. Let's see. I don't see enough of your procedures and don't like any. Oh, well, I appreciate that, Carol. Yeah, they're not really sharing my procedures anymore. So they're not even sharing to some of the people that have subscribed as well. They restrict when I post a lot of times. Some they do, some they don't. It's very strange. I'm sure it's in the algorithm somehow, but that's frustrating. But yeah, so when I went in to touch it, it was super tender. So I went so slow. I'm using a 30 gauge needle. We're just slightly infusing as I go around, and we get it to blanch, and we get the top, the surface, so I can at least cut with minimal. They don't really feel much of that. And the goal is to, if I can just make that cut and get to it, the pressure releases almost instantly, usually. And then it releases out, and that starts going down. That the pressure on those nerves instantly goes down, and you actually get a little wiggle room there to be able to push a lot better, or a little bit harder to get even more out. What happened with this one, and it was why the first provider probably had trouble. She had like almost a centimeter of tissue there. It was very thick right over it. It kind of bulked up. I think there was some inflammation, some of the induration. It had thickened with edema and swelling. And it's a kind of a thicker area of skin there, protective skin over the sternum anyways. And I cut through and nothing came out. Then I cut again and I could feel myself go into the pocket and still minimal came out. And you can see some pus. My hand's a little bit in the way, and you hear me, I think, say it in the video, like, oh, there it is. And some pus came out. It was a little pocket, and that was it. Then I thought, oh man, so we're working deep here, and I know she's feeling a lot. And so I was like, this is going to be a tough one. So I got my blunt extractor, just anything with the loop. The thing I like about that, and why I like it better than a curette, which a lot of people are like, why don't you curette? The sharp curette in there, if you're using, like a razor curette or a circular razor, you go in and start scraping that inflammatory tissue, you can cause serious bleeding sometimes that then gets in the way of what you're trying to do. Even my soft, even blunt, can still do that as well. And so I went in there and I instantly, you can even see it in the video, it was loculated. There are membranes in there as that cyst, and this happens with inflamed cysts a lot of times. It explodes. It kind of goes inside. And sometimes you may have a lobulated cyst already, which is 2 or 3 compartments, and then it kind of bursts out, and then the body starts trying to heal, and membranes may form, and then you get 3, 4 pockets, sometimes more, that are forming in there with thin membranes of like separation. And you can feel me and I grab one actually, and I kind of pull it up, and you can see it if you rewatch the video on that loop extractor. And then you see as I'm turning, just bam, I hit the main one where the cyst contents are, and I get big chunks of cyst. We get purulent discharge, just starts flowing, and I can see instantly that was the main pocket, and I was like, whew, we got there. Rub the sweat off. So that was nice to hit that. It was very, very tender when I was down in there where we were at. So, I try to go slow. I'm trying to just kind of work my way around, and you can see there, I kind of get around. I still get little pockets, even cyst contents coming. And that's how you know your diagnosis was correct. You validate it right there with cyst wall contents. So that's nice, because then when you know what you're working with there, then I kind of know what exactly I need to do. If I just hit a pocket of pus, which I have before, then you start thinking, okay, we need to make sure to culture this, because it's likely a bacterial infection or MRSA. So you start kind of, as you go, it takes you off in different directions. But I could really see why that last provider had trouble. And I generally don't have any trouble with these. I've done so many. I mean, I can tell if it's ready. You can tell if there's fluid in it. You can a lot of times tell which way the cyst blew out, if it's a cyst, if it's not a cyst. When you do hundreds and hundreds and hundreds of these, you get to understand what you're working with and what you need to do. Now, I know, in urgent cares and ERs, they see these, but it's not like a daily thing a lot of times. And even if it is, they commonly don't go real deep or get real crazy on them from what I've seen. I have even had one, and I wish I recorded this so badly. It was a big giant one, and she came into me, and I couldn't do it that day because of the insurance, but I could do it within 24 hours. So I was like, listen, I know this is hurting. If you can get through one more night, it's not going to be covered. I don't want you to get billed for it, and it's going to be, we got to get in there, and this insurance just doesn't let me do same day. They will approve ER and urgent cares, but they won't approve a specialty, an outpatient specialty, same day. And, I don't own the practice. When I do these procedures, I have to charge. And it was later in the day. I was like, listen, I'll have you back in 12 hours so we can do this first thing in the morning. And she was like, okay. And she went home, and it was hurting, and she went to an urgent care. They cut it open, and they did relieve some of the pressure, and they drained it out. And it had opened up, so they left it open, and she came in 2 days later. She went home, she had a bandage on. 2 days later, she was like, it was still hurting. She came back, and the whole sack of the cyst was literally sitting right there. Like, literally, it looked like a broken egg. It was sitting there. And I didn't have to number anything. I was like, they had to have seen that. And I just couldn't believe it. I literally took forceps and just went and pulled this giant cyst wall that they had pushed out the stuff, but the whole lining, like a cracked egg, was sitting there, and it just pulled out. And I was like, oh, I should have recorded that too. But she was in pain, and I didn't even really ask her, because she was upset on her insurance, and I just didn't want to even put that into the mix. But it was amazing. It was amazing that they didn't go the extra 10 seconds to even try that. And probably because she was in a lot of pain, and probably because they don't do many of those. And so they didn't even know what to expect. They probably didn't even know what they were looking at, I'm assuming. So that happens all the time. As part of the reason I do these videos is to show exactly what you need to do. These actually aren't all that hard. If you have lidocaine and you can get at least the top anesthetized, you can make that cut and you're good. So yeah, we got that. We talked about the pressure release and the pain and why they have pain. As that fluid, what would happen? And I get this question: what would happen if I didn't cut it? There is a cycle. The body has a way of self-healing, and the inflammatory response. So let's say we have that sac in there, and that sac's swelling as it grows. Even that swelling will start to put pressure in the area, and pressure and inflammation starts, and then cells start coming down there. Inflammatory macrophages, different cells, like, what's going on? Why is there an inflammatory response starting here? Why is there inflammation? And they start getting there, and then it's releasing more inflammation, cells that are releasing markers for inflammation, and that starts, and then fluid production starts. And so the breaking down, as it starts to break down, you get this fluid pocket that starts to form, and that inflammation will start thinning out some of the tissues, including the skin above it. And eventually, one of two things happens. Well, two things happen. That pocket, it starts to like a water balloon, just keeps swelling and swelling and swelling, and it starts pushing up on the pore that generally is involved. And as that pushes, it starts spreading open the pore and starts breaking down some of that top and areas of the dermis and the epidermis, and the skin starts thinning above it. And you'll see this. You see this all the time when people come in. They'll have a white head, generally at the top. That's just you see in the purulent discharge, and the skin is so thin, it's like literally ready to be popped. And it commonly happens in the shower under hot water, that heat, with they're either doing hot compresses or just hot water. It speeds up that inflammatory process. The markers that are being released, the more fluid production, and it's just like a volcano getting ready to pop, and it pops. It would generally pop in the shower, but if you let it go that long, you can have such a breakdown of tissue that the surface can cave in, and then you see these big open ulcers or wounds. It can get really ugly, and generally people can barely handle. They almost always are going into to see a provider before that happens most of the time. So generally will catch it. The skin is starting to thin. I can feel fluid that's there, and most of the time they are not as thick as she was, and that was happening because this is an area that had a lot of edema, swelling, pretty thick skin, and it tended to go down and it went deeper, which is why it was so painful, even though it wasn't one of the biggest abscesses I've done. But why it was so painful. And don't forget, I know I posted that one on Mr. Pops It Live. It's still coming. Don't worry. I have its follow-ups. I'm trying to get the follow-ups all done so you can kind of see it comes up quick, because I don't want you to have to wait and wait and wait, because that's an amazing one too. And he gets something called Proud Flesh. We got a lot of stuff we're going to talk about on that one. So it's such a good story. I want to kind of do 3 or 4 videos in a row with it, and I wanted to have them all done. So that's coming as well. So don't worry. With that skin breakdown or drainage, and then when that pops, it literally, people feel so much better in 48 hours. Same thing happens when we cut it, but when we cut it, if it hasn't advanced enough to thin that skin so much, you may still have loculations. You may not get, you have pockets in there that haven't broken down as much as they should to drain the whole thing. So we're cutting it before it had come to a head. You want to get something blunt in there and go around where you can. They're still going to feel it, and you can see I go and press it on the bottom, just barely. I always do that to test the sensitivity of the bottom. And when I did, she's like, I could feel her. It's instant. It's like a live wire. Like I say, they move back and they'll jump. And so I know then I can't go scrape the bottom. I just press gently on the bottom, and she could barely handle that. So I'll come up a couple millimeters and swirl. So I'm trying to get the loculations or like webbing and banding that's in the middle there, but not scrape it off the bottom. And she could handle that, and she did. And that's what got the pockets to go. So let's get to our follow-up. This is the first time Mr. Pops It Live. You're getting stuff where you're not getting it anywhere else. So that's why I recommend signing up for it. Also, I'm going to talk about what I'm doing next week, which you only hear here at Mr. Pops It Live. It's kind of exciting. I'm going to talk about it after the video. So here we go. Let's play this video. It's only 1.5 minutes. Let me get in here. Almost. Oh, I took my screen. There we go. I got to make myself smaller here. So a couple things before we start. Let me make this a little bit bigger for me. Almost. Oh boy. I don't want to mess that up. Okay. I think we're good. So you can see where I cut has come in. Looks great. It almost looks like I put running subcuticulars or a deep suture in there. It just sealed right back together. And this is 5 days out. So let's hit play, and I will close my trap.
Okay, guys, here we go. This was the sternal cyst, the large bump that was on her chest. You can see from the side here, that's gone down. And you can see the little cut we made close nicely. It almost looks like it was stitched, even though it wasn't. So that is looking good, and it's soft. So that's softened up really nice. The redness is almost completely gone. And this is just, 4 or 5 days out. So I don't feel any cyst in there right now. We did do a Kenalog injection. That should, kind of keep softening it up over the next week or two. Her inflammation is down. She said not hardly any pain at all now, which is nice, which is what we expect. And we'll see, check back in a month. If we start to see or feel that cyst reforming, then we'll do a small excision there and remove that so this doesn't happen again. But a lot of times what I see with these is they just literally kind of shrink down. The body reabsorbs what was left in there. The injection that we did kind of brings down the inflammation, and then what we drained out was maybe 80–90% of the cysts. It just goes away. So that's what we're hoping for. I'm glad she's sleeping better and feeling way better. And thanks to her for sharing, because these are interesting cases. I mean, she got over 1 million views in 48 hours on a couple different onlines. So she's doing great, and that's a good follow-up.
Here we go. So, yeah, I mean, she got... TikTok has been interesting. Everybody hates me there because I can't show procedures, and other people can for some reason. So I get a lot of people just leaning into me, but I know that they like pops. So I'm just trying to kind of Redirect. There you go. Thanks, Mrs. Popset. Redirect them to a place that has 500 videos that I know they'll like, and they're mad at me for it. But I know they've come. I've had like 40 or 50,000 of them come, and they have loved it. So that's been cool. Um, but as far as other people can show pops there. I don't know why they're not allowing me to do that. So they even are shutting down. It's been really weird, but we'll see what happens. I'm just going to keep pushing forward. I'm showing the precursor to the video so they can see what I'm working with. Anyways, that my procedures are too long really to put on TikTok. So they won't even let me link the video. No, I can paste it, and you can copy and paste it, but the links do not. It isn't like a hyperlink or whatever where you can just click on it. So they don't even allow that. It's very strange. But it's been great, and we've had a lot of good traffic from it. I know there's just a whole big group of people over there that still like what everybody likes on YouTube. They just like it a little bit quicker. So I have put links on them though, so people can see. But so with that, you see, she's doing great. She was so happy, and when I press on it, it's totally soft. Some people ask why I don't always do a Kenalog injection. Two reasons. She basically had thick tissue there, a lot of edema, and it had just popped up, and there was a lot of inflammation and what's called induration, which is the firmness to the tissue there, and it was pretty inflamed. So putting some Kenalog in there, it just speeds up the inflammation going down, which it already has. Her redness was almost completely gone. I'm going to do another 1 month follow-up for her, and we're going to check on her and see how she's doing. And what I said in the video, we're going to look for the cyst to reform, and then we just do a small excision and remove that. So, and usually it does come back as like a centimeter. They're usually pretty small as it starts to reform, and we just do focused, and it's all dry. There's no inflammation. The lidocaine works. We go in just like I just did on that mirabilis abscess. It turned into that huge abscess that reformed, and we cut it out, and he did great. So I got lots of examples of that too. So that's it. That was it was great. I thank her for sharing. She loved sharing it. She's a younger woman, so it was really neat, and she loved sharing it with her family. It's always fun when people are excited to share. They're excited to see what was in their cyst, and they share it with their family, and the family loves it. So she's like, "You got so many new subscribers for my family." I was like, "That's awesome," and it's and we get to teach as we go, so that's very cool. So next week I'm going to be in Las Vegas, and it's a kind of a dream of mine, or a passion that I play poker, and I play poker, Texas Hold'em, for many years. And I won, $3,500 this last time I went out, and I've won actually every year since 2015. Since I've gone out, I go out and play Texas Hold'em for just a couple hours. I can only do it at like the end of the day, and I got to be up early, so I never really get to put a lot of time into it. But the WPT, the World Poker Tour, is there, and all the pros from all over the world are going to be there. And the main event is a $10,400 buy-in. I'm not obviously going to do that. I would never feel right putting that much money in when I got kids that need a college education. But I'm going to take the money that I won and move it into some satellites and win my way into it, hopefully. So I'm going to do some lives from there. I'm going to be there for several days. I'm going to do some lives. I might take some pictures with some famous pros, and keep you guys posted. It's a big passion of mine. I've always wanted to play against the best in the world, and this is my first time doing it. So I could go away with my tail between my legs. Who knows? But I will say this: I've played some very, very good poker players over the years, and I've also played at the Win many times, which there are great cash games, and I do well almost always. So. I feel pretty confident, but we're gonna find out. We're gonna find out when you got a whole table of pros. It's gonna be a little different. So that's what I'm doing the whole week next week. I'm pretty excited about it. I'm gonna keep you guys posted. And I really, it's a true passion of mine. And I like it for a couple reasons. To me, poker is a lot like life in many ways. I don't consider it gambling because I'm not playing against the house. I'm playing against other people. Even though any one day you can get really lucky, and I know there is a lot of luck in any one day, but over time, playing the odds and playing them correctly, good players are at the final tables for a reason, and the pros are for a reason because it goes. But just like in life, if you never risk anything, you're not going to get much back. If you risk too much, you're going to get burned. So, knowing when to take your chances and really going in educated and being able to read people. I do feel like the job that I do and seeing people every day, I read patient types and people types and type A and type B. And that's what makes a successful poker player. I'm also extremely patient. So, and that's a lot of people aren't. So, I think we're ready to go. So it'll be fun. But I just want to let you guys know I'm gonna be doing. Yeah, I'm bringing some glasses too. And if I make it to the final table, it's televised. So talk about a great way to promote my YouTube channel. I'm gonna take my Mr. Pops It sweatshirt. If I make it into those final days and it's on TV, you can bet I'll be repping the blue glasses and maybe my sweatshirt too. So that'll be fun. If I go out early, I'll just come home early and then I'll cry for a while. Just kidding. But thanks, guys, for showing up. This has been great. A lot of people showed up. We usually get 40 or 50. I think we got 75, 80. So we had some people, I think, come from TikTok as well. And thanks for popping by. Were any questions I was going to ask? If anybody had, I kind of talked a lot and answered most of the questions on that. But if anybody had one, I don't think so. I think we had kind of covered a lot of those questions. So, yeah, thank you for the good luck. And thanks again to Laura from Chicago. I think one of my biggest fans. I really appreciate she does the super chat almost every time. I appreciate that. Thanks so much. So you guys have a great night. I know East Coast, it's really late. I've never done like a live on the weekdays. So Mrs. Pops It, so sorry she had to put the kids down all on her own. And that is a job in and of itself. So thank you to her as well. All right, guys, signing off. Have a great night, and we'll talk again soon, and you will see me next week. I'm going to do some lives. We'll see you. And here.